Good morning, everyone. My name is Tarun Dalia, one of the first-year cardiology fellows at University of Kansas Medical Center. First of all, I would like to thank organizers for giving me the opportunity to present at this platform. So today we're going to talk about a case of a 20-year-old Caucasian male who had a sudden cardiac arrest while playing basketball. As soon as he collapsed, bystander started doing CPR and AED pads were attached. He was found to be in shockable rhythm and a shock was delivered. Soon the EMS arrived. They found him to be in ventricular fibrillation. Another shock was delivered. At that time, the ROSC was achieved, and then he was transferred to the nearby hospital, and he was intubated for airway protection. He was started on amiodarone drip, and he was found to be hypertensive, so they put him on vasopressor medications. Emergent bedside echo was done that showed severely reduced left ventricular ejection fraction of 10 to 15%, and he was taken to the cath lab emergently. It showed normal coronary anatomy. An intra-aortic balloon pump was placed, and he was transferred to our Center for Advanced Heart Failure Therapies. So he has no pertinent past medical history, surgical history, or family history. When he arrived to our hospital, he was accompanied by his mom and dad. He is a college student. He is single, no kids. He has 2 siblings, both healthy and alive, no cardiac history. He drinks beer occasionally and had hard liquors sometimes. 1 week prior to presentation, he had ecstasy at a college party. That was spoiled by the mom and dad. So on vital signs, he was afebrile. His blood pressure was with a map of ATA with 2 vasopressor medications, dopamine and Levophed. Pulse rate was 89 to 99 per minute. He was not tachypneic. He was setting 98 to 100% on the ventilator. On physical examination, it was unremarkable. He was intubated and sedated. There was no JVD. There was no pedal edema, and extremities were warm to touch. This is the EKG on presentation to our hospital. We don't have the VFib strip that was the EMS shocked him on, but you can see it's normal sinus rhythm over here, but there are no QTC prolongations. The pertinent labs include elevated white count 27.3. His CRP was high to 3.8. D-dimer was almost 10,000. Normal kidney function, lactic acid was 1.2. His CK was 3,000. Elevated AST and ALT. His urine drugs were positive for THC and benzos. Troponin was significantly elevated to greater than 22.9. In our lab, we don't go more than that, so that's the highest value we can get for troponin. Aldolase was 14.2. So at this point, we activated the STAT transthoracic echo, activated the cath lab for right heart cath, and endomyocardial biopsy, and possible need for more advanced mechanical circulatory support device. And on-call pathologists were informed for biopsy interpretation. So this is the transthoracic echo we had. As you can see, severely reduced both left ventricular and right ventricular function. EF was like around 5-10%, but there was no pericardial effusion or tamponade. Right heart cath showed severely elevated RA pressure and wedge pressure, suggesting of elevated left and right side filling pressure. His PAPI score was 0.83. His PSAT was 48%. His cardiac output cardiac index was reduced. By thermal method was 2.75 and 1.35. And by FIC, it was 2.52 and 1.24. So he was in biventricular failure, cardiogenic shock. At this time, we activated the shock team. In our hospital, the shock team comprises of general cardiology, fellow intervention cardiologist, cardiothoracic surgeon, anesthesiologist, and the advanced heart failure cardiologist. So they discussed the case, and the decision was made to use VA ECMO as a bridge to recovery because of this biventricular failure. And we already started the heart transplant evaluation at this time as an exit strategy if in case he doesn't recover. By this time, we had the pathology results back that showed there was an infiltrate consisting of mixed mononuclear cells and mixed neutrophils. There was a focal associated myocyte damage, which goes along with diagnosis of myocarditis, but there was no lymphoid aggregates and giant cells, and no organisms were identified. And hence, the diagnosis of fulminant acute myocarditis was made. The patient was then transferred to the CT ICU on VA ECMO support and was on vasopressor medications and had an indwelling PA catheter for the hemodynamic monitoring. So the patient was taken care by a multidisciplinary team, including advanced heart failure cardiologist, CTS, and critical care anesthesiologist. We did not use any steroid or immunosuppressive medication. On the day 2 of the presentation, patients started showing sign of echocardiographic and hemodynamic recovery. So day 3, we decided to turn down the VA ECMO using echo and the PA catheter guidance, and we were able to wean him off the VA ECMO on day 3. And the day 4, he was extubated. After that, his hospital course was pretty unremarkable. He had some hospital delirium, but on the discharge, he was alert, oriented, and had full neurological recovery. So he was discharged on day 7 to day 8. EP was consulted for his history of VFib, and they decided to discharge him on life vest without any ICD implantation. I think that goes along with the ACC and ESC guidelines. So this was his echo prior to discharge. You can see the full recovery of the LV function, RV function, pretty robust, like 60-65% EF. Just few points about fulminant myocarditis. I think this is the third leading cause of sudden cardiac death among the young athletes. It can be caused by a broad range of infectious agents, but it can also happen from non-infectious trigger like toxins and hypersensitive reactions. I'm not sure whether the patient who took ecstasy 1 week prior to presentation led to some hypersensitive reaction that led to that, but that I'll open up to discussion afterwards. Patients can have clinical presentation of acutely decompensating. They can have cardiogenic shock-like pictures and have fatal arrhythmia like our guy had VFib. Endomyocardial biopsy is still the gold standard for diagnosis. But cardiac MRI has shown sensitivity to 100% and specificity up to 90% in diagnosing myocarditis as compared to endomyocardial biopsy. But if it's done between 2 to 3 weeks, then it's pretty good. But if you do it after 3 months, then it loses the sensitivity and specificity. Initial treatment is usually supportive, including intubation. You can use suppressor medications, inotropes. Mechanical circulatory support devices have shown favorable outcomes. It has shown, I was reading literature, that more than 70% of patients can have survival after in the hospital admission when they are placed on mechanical circulatory support devices. Tissue diagnosis really help in guiding the treatment because there are some myocarditis like giant cell myocarditis, eosinophilic myocarditis, in which you need to have immunosuppressive medications right on board. But other myocarditis like lymphocytic myocarditis, the use of immunosuppressive medication is still controversial. With this, I would like to thank my mentors and I'm open for any questions.
That's an excellent case, but it also highlights how beautifully your hospital shocked from the initial presentation to the escalation of care to the involvement of the shock team, because you have it protocolized that this patient got the right care at the right time and had a very good outcome. Any comments from anybody? Go ahead.
I just want to congratulate you, like Biswajit said, on the timing here. There was a manuscript generated years ago from the Hopkins team. It was called the Fellows biopsy-based and right heart cath-based database, which showed that fulminant myocarditis with acute and early mechanical support. And what was that back then? This is bi-sided thoratex. this is bi-sided thoratex. Centromags, not around. This is bi-sided thoratex, had the best early and long-term survival of any myocarditis, whether fulminant or not. That was impressive. It's interesting, I think, to Biswajit's point, the early great decision because of bi-sided failure to go to ECMO. It goes against some of what people say about ECMO. Yes, it doesn't unload the LV, but guess what? This is an inflammatory condition. You rested the heart to some degree, and look at the recovery here. No balloon pump was put in for venting or nothing, right? He just started ejecting probably within hours.
So he had a balloon pump when he was in outside hospital.
I see.
Then he was transferred here, but then when we put the ECMO in, on the same day we removed the balloon pump out.
So you took the balloon pump out? Is that because you started seeing ejection, or that was just a decision made by the shock team?
It was a decision made by the shock team at that time. They said we put ECMO. They waited for like a few hours, but then they took the balloon pump out. They said maybe he recovered well. I know what was the reason behind that, but that's how they did it.
I just want to share one last thing. ECMO and fulminant myocarditis, I reviewed the literature for Christian Bermudez when we were looking at our recovery data. Japanese study, beautiful study focused on myocarditis. It's kind of like what you expect in shock, kind of a 50% survival. But of those that, this is overall, but those that got early ECMO, 80% survival with great long-term survival. And, this is a young man. And anyway, any thoughts on how else you could have managed him if you didn't have ECMO? I'm curious, because to his point, you, of course, are a center of excellence doing shock. But what if you're not in an ECMO center?
So at that point, I would have thought, he had a biventricle failure. I would have gone with the Impella and the RV support. If you have used the Protect 2 for RV support, and we can use the Impella for LV support, this way we can manage both the biventricles in his case.
So that you can just take it from vast majority of people, how this case would have gone. would be he go to a primary care hospital where they would start him on 2 pressors and then put him on a balloon pump. And then he'll go to some secondary care who would put an impeller, and then he'll get an Arpella. And then once he's crashing and coding, then he'll get an ECMO. By that time, the horses have left the barn, and this guy would have had a very different outcome. And this just goes to the point, timing is everything. And you recognize very quickly this is a diffuse process, which is biventricular, and you didn't dilly-dally and went straight for the maximal support. I think that was the key to this case. Any point? Anybody else? Yep. Oh, I'm sorry. Yes,
Yeah, great case. I really loved it. Great save for the patient, obviously. Just for the the steroid treatment, I know the data is conflicting. We do that relatively regularly, and I've never seen a lot of harm of that. So that's the only thing I would have done differently. I think I would really started aggressively on steroids. But I know that there's no good randomized data for that. But I think the harm is relatively little in those cases if you just give a one bolus shot injection.
But there is data coming out in that, although the MITI trials did not show any benefit. That was a very short randomized trial, so you cannot extrapolate it. But the problem is now we understand there are 2 ways fulminant viral infection cause myocarditis. One is the cytolytic effect of the virus directly, and one is the inflammatory response with that virus. That one benefits from steroids, but if it's a direct cytolytic effect, theoretically, you can make it worse by giving steroids. So that's why many centers, this is not a settled issue by any means. So. Thank you very much.
Thank you for having me.